So I'm Katrina, and I'm the state epidemiologist in Oregon, and I think that there are sort of two things that I've gotten out of the training. One is, even in a state like Oregon that's on the West Coast, we've had to deal a fair amount with Ebola. We've had people under monitoring and people we've had to investigate, and there's been a fair amount of media coverage and press conferences. And to see how that little piece, but as part of this much larger, not only national, but international effort. And so a lot of the training has been about sort of the bigger picture vision about what's been happening with the Ebola response, like I say, in the United States and the world. More specifically, of course, to the activities that we're going to do, we're not going to affected countries where it's clear the outbreak is happening, hopefully waning in a couple of the countries like Liberia, but still going very strong in Sierra Leone. But the unaffected countries, how, if Ebola were introduced in another country, how would you be able to detect, how would you get specimens, and then what to do about it, the sort of contact investigation to limit that. And I think there's both the immediate, that's part of the Ebola response, but then, since we're going to the non-affected countries, although Mali has been affected, but part of that is that, this may be the current Ebola outbreak, but if this were to happen in the future or other diseases were to happen, how does this help to support the infrastructure of public health response in West Africa?
She said it all.
We were asked, we were told we need an elevator speech, and so you like my elevator speech?
Yes, it was good.
Perfect.
No, it's good to have an overview of what's going on and all the different aspects of CDC. We got the view from the state. I'm a state epidemiologist in Louisiana, but we don't see the whole picture and the big effort that CDC is doing outside of the US. And so it was interesting to see all the different aspects of what they are doing. And we are going to use that to see what we'll do during this time in the countries.
My name is Jean-Marie Maillard. I'm from North Carolina, where I work with the Division of Public Health. And this week has been a week of orientation, because we're deploying on a type of assignment that's different from what we normally do. So we've spent time learning about and reviewing the outbreak, how it's evolved, what kind of response has been offered both locally, internationally, and specifically by CDC staff. Here we got a lot of orientation about what it is that CDC can offer, and so because this was new for us, so we had to learn that. And the lead really is rapid detection, rapid containment, contact tracing. The idea is also to build up capacity for the future. So we're learning about how to set up emergency operation centers, what gets involved, what are the resources that CDC can offer, who else will be there, what's been done before we deploy to these high-risk, non-affected countries. And all of that was new for us, so we've taken a lot of information in a very short period of time, hopefully to make good use of it once we're over there, because we have a little bit of uncertainty about how communications will be, so we're trying to get as autonomous as we can and hopefully still rely on exchange and support, but we're taking as much as we can in that week.
These CSTE contracts are very useful, although, we work in Louisiana, I work in Louisiana, that's where I am all the time. I did already 5 consultations with CSTE for influenza surveillance, mostly in Africa, and you have a better understanding of the disease once you have gone outside and see what's going on. I mean, for an epidemiologist that stays in the state, it's very interesting to get that experience to go see public health in other countries. And I would recommend any of them to, if they have an opportunity to take off and go get that experience with CSTE. That takes good care of us, everything is well organized. Just a few glitches, but not that many. It works well, it's a very interesting experience.
And maybe I could comment just a little bit, because I've also done a flu surveillance evaluation with CSTE. And that I think was a little clearer. Those are ongoing, they go to a variety of countries, there was a template to use. I think what we see with Ebola, of course, is that we are part of a response, and whatever metaphor people like to use about building the boat while you're sailing it or whatever, but it's true, when you're in the middle of the response, you don't have the same opportunity to have a very calm, thought out exactly what you're going to be doing. And so I think one of the reasons that they had asked senior epidemiologists is because we certainly need resources, but we really need to evaluate what's needed in these countries, and it's not nearly as prescriptive as the flu surveillance evaluation was, for example. So, but that makes it interesting too.
In Mali, I had a few cases. The first case was imported, no secondary one. And then there was a second case that was imported, and they had several secondary cases, but they were able, with the help of local people and international people that were there, to completely stop the outbreak. And Mali is getting out of the list of countries where there is sustained transmission of Ebola. So they have done a very good job there. And I think the idea is to see what's going on, how they did, what were the factors that contributed to their success, and try to formalize that so they have a system that will continue like that, because the outbreak is not going to go away anytime soon.
I am going to Senegal, and Senegal has seen one case in August of 2014. We're now in January of 2015. We're seeing good progress made in Liberia. We're hoping Sierra Leone also is getting on the right end of the epidemic curve. But we don't know. A lot of the reason why we're being sent to help prepare is there could be reintroduction at any time. So in Senegal, there's been a lot of work done to try to set up an emergency operation center, because it really helped a lot in places where you have it. And we've learned that initially in the 3 most affected countries there was nothing like that, and it was chaos, and it was very difficult to organize response. So I'm going to a place where there's been several persons from CDC and a lot of people from international organizations and national humanitarian organizations who've done some work. So part of it is to link with the pre-existing work that's been done and see how we can contribute to get it to a better place. 30 days is not that long, so we'll have to quickly figure out what it is that we can contribute and put in place. But just to extend on the previous discussion, we've also learned about the huge resources that CDC has to offer, the budgets that are being put in place, and that's very significant. So how to best put that in place. And several of us are deploying with public health advisors. Their role will be more how to link these budgets to effective use.
So Benin is a little bit less evolved, I think, though there haven't been any cases of Ebola in Benin yet, luckily. And the other thing in Benin is there is no CDC country office, and so there is a CDC presence. There's an individual who works with the malaria initiative, and so there are folks there, but again, it's a little bit of a smaller scale. And so I think what you're hearing, again, is that the different countries, there's different work to be done. One of the things that we've all heard is that CDC is trying to roll out a training course over the course of the spring, the field epidemiology training course, and they're trying to put this in effect in different countries. And so one of our goals is to make sure that that's possible to do, that they've identified who could be the point at the Ministry of Health, that they want CDC to come in and identify who the participants would be as part of that training. Now, when you have generic training, and I think they're going to be rolling it out, one of our colleagues, Eric Brenner, is going to Cote d'Ivoire and actually will be there when the first round of this training is going to happen. So lessons learned from Cote d'Ivoire, but of course that will be very different in Benin. So one of the things we're going to be doing in Benin as well, in addition to hopefully laying the groundwork for a training to occur, but is to do some assessment of what's happening at the district health department level and what the needs are, where the gaps are, because this kind of training would need to be tailored to that. So again, without having a CDC country office, that is one of the things that CDC would like to establish in each of these countries, and so starting to have some conversations about what would it take to have a larger ongoing presence than just one individual working on malaria. And I think people are open to that. But so a lot of this is putting things in place, building. There have been a couple of other CDC folks who've been in Benin already as part of the Ebola response, and there will be people coming after us as well. And hopefully CSTE colleagues, this relationship will continue. But so to be sure that the work that people are doing builds on what's happened already there. Because I think people are very open to it. When again, the problems when you have this kind of emergency is that, and our deployments are 30 days, I think, or you're staying 6 weeks or something, but they're very short, and so you can't get a whole lot done, and then I'm going to go back to Oregon. And so who takes over the work or make sure that the groundwork that's being laid is not, that it doesn't have to be reinvented all the time? Because I can imagine that the countries that we're going to don't want to meet yet another group of Americans coming over to do good and then leave and nothing is left in place, and then another group comes over. So that sustainability, I think, is important.
I think we just came out of a session where the emphasis was on the organization of the response. And so we've gone through SARS, through influenza pandemic, through a number of situations, and Ebola response now, where it became very clear to all of us at the state level that having some kind of efficient communication and distributing roles, I mean, having people able to know who's in charge of what will help, and they're trying to replicate some of this organization. That's one aspect.
I think from my perspective, one of the things that was clear, because we had a nice presentation from the EPI team here at CDC that's mostly doing surveillance for the highly affected countries. And the quality of data that comes in is very variable, and they use different case definitions, and so that's sort of standard. But even that aside, just how well these reports come in, and do they come in electronically? Do they come in on cell phone? That is, even in an Excel spreadsheet, but at least the spreadsheet is filled out. Or are they filled out by hand? And what the quality of those data are, they're supposed to be submitting daily reports and then weekly, and guess what? The weekly is not the sum of the daily, and so figuring out where those issues are. Confirming, again, I mentioned case definition, but suspect, obviously somebody who's had contact with someone with Ebola, and then comes down with symptoms, that's suspect. But that's not so much what they're recording some of that, but it's laboratory confirmation. So how do you get the laboratory specimens? How do you make that happen? There is no Ebola testing unit or testing laboratory in Benin. So the time that it takes from a patient to present with symptoms to a diagnosis, to doing the contact investigation, to identifying. So it's very, again, we haven't been in the field yet, but our understanding is that it's very, very rudimentary, just the standard things that any epidemiologist thinks about. What's the case definition? What numbers are you counting? And then, of course, we always want to know what the denominator is, and in this case, I think that's very difficult to find out how many people are living in an area. But so it's a lot of numerators, and then how do you actually get the confirmation, and how do you track this, and what are the trends over time, because that's really what now is being used, at least in the highly affected countries, to start guiding some of the interventions, the contact investigation, and safe burial practices, and infection control, and all of those kinds of things really need to be targeted where the epidemic is hitting the hardest.
And the solution to prevent this disease from spreading is to understand where they are, how they are transmitted, who's catching them. Fairly often people have the impression, well, there is some disease being transmitted, so we are going to build a wall. And then you find out that people go over the wall, under the wall, around the wall, and the disease keep on going. Isolation, building walls, even treatment fairly often are not the final solution. The final solution is to understand what's going on in the population. How does the population look at it find out who are the high-risk group. If you have a good treatment or a good vaccine, it's very nice, but you need to know who you need to immunize first. You need to know who needs a preventive treatment, if there is a preventive treatment. You really need to understand what's going on in the population. And if you look at all the major scourges that we have throughout the ages, the plague, the leprosy that was rampant in some old days, it's always knowing how it's being transmitted. The cholera is an excellent history where knowing what was going on in the water in London, they could prevent it. So it's a science that not many people understand. You know, you look at treatment, you look at vaccine, you look at needles, and epidemiologists are just bean counters. And fairly often, you know, little kids ask, what do you do in life? I count sick people. And counting sick people gives you a lot of information, and it's very useful.
Just to build up on what Katrina was saying, we're going to unaffected countries, and so part of the discussions was, well, improving surveillance. How can we get, you know, daily reports even from places where 0 cases were seen? So that's kind of the next step in some places where is that possible. And if a detection, if a suspect case is identified, trying to do everything we can for a rapid response. We've heard of examples where there were meetings but no decisions made in the early days, and so it's trying to turn the rapidly, you know, what's the way to do control? How do you start contact tracing as quickly as possible? Is there a 72-hour plan for the first steps very quickly, so everybody knows or can follow a plan and have a sense of the gain you can make if you react rapidly, as opposed to improvising and being less in control of what needs to be done.
Well, eventually Ebola is going to go away. The goal is to get to 0 cases in these 3 areas. And sometime later it's going to pop up somewhere in a small remote village like he has done before. Hopefully we have learned the lesson that when it pops up in a small village, we need to jump on it and not expect it to die with a local response. So that's, and then there will be another disease that come out from, you have the impression that you have a limited number of viruses and bacteria, and in fact, you know, many viruses are in all these animals, and we get closer contact with the animals. Look at HIV. It existed for a long time. It was limited in some forest area. Then it got out, and you had tens of millions of people that were affected. And this is not the first time that we are going to see new diseases that are coming up. So we should learn the lesson that, you know, living in the US and focusing on our problems is not going to prevent major catastrophes in the future. The world is getting closer, and we have to watch what's going on a little bit everywhere.
Yeah, and I guess to echo on that, I certainly think of Ebola, but you know, in my career in public health, which has been about 25 years now, we certainly had SARS, and I like to use SARS as an example when I'm talking to people about what we do, because again, it's identifying cases, and then there was no vaccine, there was no treatment, and it was standard, you know, contact investigation and isolation and quarantine, and that essentially died out. I mean, it was a huge outbreak, obviously, in Southeast Asia, and then it had sort of a couple of foci in Canada, imported cases both in British Columbia, and then Toronto had a big outbreak. But it did go away, and no one really talks about SARS anymore. And so Ebola is a little similar. I agree that it will go away, and hopefully there's a vaccine. There's certainly one on the horizon, which we can hope is effective, and that might deal with this. But we need to keep using some of the fundamental tools. Again, as epidemiologists, we are the people who count the numbers, we count sick people, but we like to put them in context, whether it's time, place, person, and what's the denominator, so that you can use that to focus your interventions. But I'm always afraid that people think that the latest bells and whistles, you know, are going to be, we're going to have the disease. And what's interesting, of course, with Ebola now, PCR testing. Well, we didn't have PCR testing, you know, 15 or 20 years ago to routinely. So we can have new diagnostic tests. But often the control of these diseases isn't just the treatments and or even vaccines. I mean, that's extremely important. I'm obviously a very strong advocate for vaccination, but it is some of the standard infection control practices, clean water, latrines, and you know, having a safe way to handle people who are very sick and then dead, and safe burial. All of those kinds of things are really important because we don't know what the next virus is that might come. We've been talking mostly about viruses. It could certainly be other infectious diseases as well. So that's part of what I find interesting is you really go back to the fundamentals that during my day job, you know, in the United States as a state epidemiologist, we're dealing with, you know, the most advanced medicine and science in the world, but it really is the fundamentals around infection control and data and using data for, you know, those contact investigations. That's as important, if not more important, than sort of the technology.
The end of this outbreak is zero incidents, as Raoult was saying, and so we think we're getting in that direction. It will take a few more months. On the other hand, the wider issue of global health security is there's no end to that, and the examples of SARS and Ebola are reminders that anything happening in the world that's human-to-human transmission, we should remain vigilant and concerned if a situation like that comes up. Sometimes new disease or newer forms or manifestation of illnesses that have been around at the scale of this current outbreak, for example. When the first MMWR on this outbreak came out, I think it was April or May, I looked at it in my office and I was thinking, should I forward that to my little group, you know, 20, 30 staff, and I did not. And I thought again about that later on, and I thought, because it came to my mind, I thought, are we going to have to be concerned about that? And this has been a long debate. I mean, should we be concerned about what's happening at the other end of the world? And yes, we should. Sometimes it becomes a lot more obvious as we saw. So not really an end to that. And so we're better prepared. The capacity building is something that's very nice to see. This outbreak is happening in some of the poorest countries in the world, and it's affecting healthcare workers in particular. They're very exposed. We've heard that in Sierra Leone they started with some of the rates of physician per population that's in the lowest that we've seen. I think it was like 3 per 10,000 initially. They've lost 10 or 11 physicians so far. There were not many to begin with. So the capacity building is something very, very nice to be participating in too.